You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about cardio-obstetrics. We'll go over general expected changes in pregnancy, pregnancy risk stratification, thromboembolism in pregnancy, MI in pregnancy, and end with hypertensive disorders of pregnancy. Let's start with the expected changes of pregnancy. In pregnancy, you have a 40% increase in blood volume, which increases the preload and thus the stroke volume. You have a decrease in systemic vascular resistance and pulmonary vascular resistance. You'll have an increase of heart rate by 10 to 20%. Combined, the above changes result in a 30% rise in cardiac output. There is not a consistently large change in blood pressure. Blood pressure can stay the same, go down, or go up. Normal physical exam findings during pregnancy that can mimic heart disease are a systolic flow murmur in 90% of individuals and an S3 in 80% of individuals. There will be a brisk and full carotid upstroke. The JVP can be normal or mildly increased. You will have a displaced and enlarged apex, and you may have varicose veins and edema. It is not normal to have the following during pregnancy: an S4, as opposed to an S3 that's seen in 80% of pregnant women, a loud systolic murmur, any diastolic murmur, or fixed splitting of the second heart sound. What are some expected echo findings in pregnancy? You're going to have mild chamber enlargement. You'll have increase in the LV outflow tract VTI, velocity time integral, which is a surrogate for cardiac output. As we mentioned earlier, that cardiac output increases by 30% in normal pregnancy. You'll have an increase in left ventricular mass. Valvular regurgitation may be possible, some mild pulmonary tricuspid or mitral regurgitation. The ejection fraction should remain unchanged. You may have a pregnancy-related small pericardial effusion in up to 40% of patients. Now, how about labor and delivery? Labor and delivery causes a very impressive 60 to 80% augmentation in cardiac output. There's increased blood volume with uterine contraction, increased venous return, followed by volume loss during delivery. In terms of pregnancy risk stratification, vaginal delivery is feasible and preferable in most cases. Reasons for C-section other than OB reasons are warfarin anticoagulation, unstable aorta, or fetal or maternal instability from cardiovascular disease. There are 4 classes, WHO risk class 1, 2, 3, and 4 in terms of pregnancy safety. It's a bit difficult to remember, so I'm just going to go over the class 4 patients who are the very high-risk patients who you should counsel to avoid getting pregnant. These are patients with PAH, pulmonary arterial hypertension, severe ventricular dysfunction with an EF of less than 30%, New York Heart Association 3 to 4 symptoms, previous peripartum cardiomyopathy with residual LV dysfunction, EF of less than 50%, severe obstructive lesions such as severe mitral stenosis, severe symptomatic aortic stenosis, or severe recoarctation, severe aortic enlargement, which is defined as more than 45 millimeters in Marfan syndrome, more than 50 millimeters in bicuspid aortic valve, and ASI more than 25 millimeters square in Turner syndrome. Also, vascular Ehlers-Danlos and Fontan with any complication. These are the WHO risk class 4 patients who should not get pregnant if possible. If a peripartum cardiomyopathy patient's LVEF recovers to 50% and above, that places them in WHO class 3 in terms of future pregnancy risk. They will have 20% risk of relapse. If the LVEF does not recover, remaining at less than 50%, that places them at WHO class 4. Now let's talk about thromboembolism in pregnancy. Neither unfractionated heparin nor low molecular weight heparin crosses the placenta, so both are safe in pregnancy. Low molecular weight heparin is preferred because it has fewer bleeding episodes, more predictable therapeutic response, and lower risk of HIT and longer half-life, and less bone mineral density loss. Low molecular weight heparin, i.e. Lovenox, is usually continued until 24 hours prior to planned delivery, at which point it is held in order to minimize the risk of obstetric hemorrhage. During these 24 hours, patients at high risk for VTE recurrence, such as acute PE or proximal DVT within the past month, are switched to IV unfractionated heparin, which is discontinued 4 to 6 hours prior to delivery. When treating acute VTE in pregnancy, the low molecular weight heparin or the unfractionated heparin needs to be restarted 6 to 12 hours after delivery and continue at least 6 weeks postpartum. Warfarin is teratogenic, so it shouldn't be used in trimester 1, but in trimester 2 and 3, it can be used in certain high-risk patients who need it. If you must use warfarin in trimester 1, for example, due to a mechanical heart valve, you have to keep the dose to at most 5 milligrams per day. If the pregnant patient's indication for anticoagulation is anything other than a mechanical heart valve, i.e. non-MARM AFib or VTE, or if they are requiring warfarin doses exceeding 5 milligrams per day, then they should be managed with subcutaneous low molecular weight heparin. There are no studies on DOACs in pregnancy, and they cross the placenta, so they aren't used in pregnancy. Combined OCPs, or specifically any estrogen-containing OCPs, are contraindicated in women 35 years older or higher who smoke 15 or more cigarettes a day, hypertension 160 over 100 or higher, migraines with aura, diabetes mellitus with end organ damage, because these conditions have increased risk of ischemic stroke and cardiovascular events if estrogen-containing OCPs are added. Now let's talk about MI in pregnancy. MI is a rare diagnosis in women of childbearing age, but pregnancy increases the risk of MI 3 to 4-fold. When MI occurs in pregnancy, it is frequently not atherosclerotic. 43% are from SCAD and 27% are atherosclerotic with or without intracoronary thrombus. The majority of pregnancy-related MIs occur in the 3rd trimester or the postpartum period, and 2/3 of them are anterior in location. MI medications during pregnancy, aspirin, clopidogrel, and heparin are okay during pregnancy and lactation. DOACs and statins are not allowed during pregnancy or lactation currently, but that may evolve in the coming years. These are typically stopped before pregnancy. If STEMI occurs during pregnancy, you just go ahead with PCI with drug-eluting stent and DAPT, but just hold clopidogrel 7 days before scheduled delivery. Now, how about pericarditis in pregnancy? If pericarditis occurs during pregnancy, your typical therapies such as colchicine, NSAIDs, prednisone, and aspirin are okay, except if the pregnancy is more than 20 weeks, you cannot use NSAIDs or aspirin because it will close out the ductus arteriosus of the baby. In lactation, aspirin is not allowed, but NSAIDs are allowed. Now let's talk about hypertensive disorders of pregnancy, which is a longer topic. Hypertension complicates 6 to 10% of pregnancies and are the leading cause of maternal and perinatal morbidity and mortality worldwide. In the US, hypertension still accounts for 15% of maternal deaths in the US, mostly from intracerebral hemorrhage. Hypertension in pregnancy is described as mild to moderate if it's 140 to 159 systolic, 90 to 109 diastolic, and severe if it's 160 or above systolic, 110 or above diastolic. The hypertensive disorders of pregnancy are chronic hypertension, gestational hypertension, and pre-eclampsia. Chronic hypertension. That's blood pressure of at least 140 over 90 millimeters of mercury that either predates pregnancy or develops before 20 weeks. Gestational hypertension. That's de novo blood pressure of at least 140 over 90 developing after 20 weeks of gestation without the systemic features of pre-eclampsia such as proteinuria. Since 25% of women initially diagnosed with gestational hypertension go on to develop signs of pre-eclampsia, the diagnosis of gestational hypertension can only be finalized postpartum. Pre-eclampsia refers to de novo blood pressure of 140 over 90 and above after 20 weeks of gestation, and often also proteinuria of at least 0.3 grams per day. Pre-eclampsia with severe features is diagnosed if any of the following features are present: systolic blood pressure of at least 160 or diastolic blood pressure of at least 110, new onset cerebral or visual symptoms, severe persistent right upper quadrant or epigastric pain unresponsive to medication and not explained by an alternative diagnosis, platelet count less than 1,000, serum creatinine more than 1.1 mg per dil, pulmonary edema, serum transaminase at least 2 times upper limit of normal. What about HELP? HELP is a severe variant of pre-eclampsia that has hemolysis, elevated liver enzymes, and low platelets, hence its acronym name HELLP. Eclampsia, which is the occurrence of seizures that cannot be attributed to other causes, complicates 3% of pre-eclampsia. What is the target blood pressure in pregnancy? For a new diagnosis of hypertension during pregnancy, such as gestational hypertension or pre-eclampsia, the treatment goal is to target blood pressure less than 160 over 110 and prevent severe hypertension. If they are in the 1s, just let them be. For existing diagnosis of hypertension, such as chronic hypertension, the treatment goal is to target blood pressure less than 140/100. Antihypertensive medication in pregnancy is only initiated for severe range blood pressures, systolic blood pressure more than 160, or symptomatic mild range blood pressure. What antihypertensives are safe? First-line antihypertensives in pregnancy are labetalol and nifedipine. Metoprolol, verapamil, and diltiazem are other beta blockers and calcium channel blockers that can be used. Diuretics such as furosemide or hydrochlorothiazide are always okay. Hydralazine and methyl dopa are also safe in pregnancy. ACE and ARB cannot be used in pregnancy. Although these antihypertensives are effective in treating hypertension during pregnancy, they are not effective in preventing pre-eclampsia. For severe pre-eclampsia and eclampsia requiring acute lowering, you can start by giving 10 milligrams of oral nitroglycerin up to 2 doses. If IV is needed, give 5 milligrams of IV hydralazine up to 3 doses 20 minutes apart. If blood pressure is still above 160/105 despite 3 doses of 5 milligrams IV hydralazine, then start a drip, either nicardipine or labetalol. Of course, at all times, maternal fetal medicine should be involved in driving the ship. If there is pre-eclampsia with severe features, IV magnesium is used to stabilize cerebral cell membranes to prevent seizure, treating to a magnesium level of 5 to 9. Should you deliver early? If gestational hypertension or pre-eclampsia without severe features, then 37 weeks is the cutoff for delivering early versus expectant management. If pre-eclampsia with severe features, then 34 weeks is the cutoff for delivering early versus expectant management. Methyl dopa can cause direct Coombs-positive hemolytic anemia or warm hemolytic anemia, which is the development of IgGs against RBCs. Methyl dopa is a very popular medication for blood pressure control. That's all for hypertensive disorders of pregnancy, pericarditis and MI in pregnancy, thromboembolism in pregnancy, pregnancy risk stratification, and expected physiologic changes in pregnancy.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.